spontaneous? What does that mean? Doesn't need to be expressed. That means there is a swelling which gets filled, then ruptures and it discharges. That would be spontaneous. Otherwise, there could be swelling which you have to squeeze to bring the discharge. That's it. Spontaneous is indicative of something which is
inflammatory or traumatic,
which is already described as a recurring phenomenon. It's a recurring sinuses in the axillae, preceded by swellings, recurring swellings in the axillae, which each time become all right after discharge. That's your story?
Yes.
In a patient who has taken antitubercular treatment in the past, who has constitutional symptoms of tuberculosis, like evening rise of temperature, weight loss, loss of appetite. Now, past history. Now, this past history is important. Therefore, you may actually start your history of present illness also by mentioning it, because you want to support your diagnosis at some point. Known tubercular defaulter presenting with discharging sinuses in the right axilla. So what have you done? You've already given an impression in your history. The patient was treated for tuberculosis. It comes too little too late. Past history. By the time I arrive here, I may get restless if it is a short case. So what would you do? If you go back, it is a case, patient has a 28-year-old gentleman presented with multiple discharging sinuses bilaterally for the last 4 months. He's a known defaulter of tubercular treatment. Is that clear?
Yes, sir.
It's too important a history to be left for the last, because it will change your entire approach. And this is not his personal history. You already mentioned it. Drug defaulter, tuberculosis 8 years back with no history of substance abuse. Perfect. Previous history of swelling discharge 3 years ago, resolved spontaneous, no history of hospital admission or any surgical intervention. That's fair enough. Personal history. Now he's a drug defaulter, that is already covered. Now what do you take in personal history, Masood? What are the points in personal history that you normally take?
Appetite, weight loss, sleeping pattern.
Appetite, sleep, next.
Bowel and bladder.
Diet,
Bowel and bladder.
speech, appetite, sleep, diet, addictions, and bowel bladder. Besides this, nothing else. If you're adding everything to personal history, it will get bulkier. You mentioned sleep, you mentioned diet, you mentioned appetite, but you brought in ATT here, which is not required, so not necessary. Now let's come to the examination, which was, I think, by and large all right. Here you should be already prepared mentally. I have a patient with axillary sinuses, which I'm already thinking is tubercular. So I have to create a scenario where my examiner thinks like I think. It should be the other way around. So then there is a problem. The general physical examination, you are trying to bring up nutrition as an important issue, where he's saying his patient has lost weight. Patient is a known tubercular case, so you're looking at fever, which is important. You're looking at muscle bulk, BMI, so that was aptly covered. What I'm trying to say is, here it won't really matter, the pulse, rhythm, etc., etc. But if you can finish it in one breath, it's okay. Built thin, emaciated, is well-oriented, time, place, and person. Why did you take this history?
So, often in tubercular patients, first of all, it is obviously important to know that the patient is oriented, time, place, and person. If the patient has a previous history of tubercular meningitis,
suppose one is not. Why do you have to be obsessed with tuberculosis for that?
So,
If somebody is not oriented to time, place, and person, what will happen? Why should you know this?
patient will not respond.
The history won't be reliable.
So how would you consider him a reliable historian? His history may not be correct.
Correct. Yes.
Sit in the front, Oscar. Sit here. He has to be oriented to time, place, and person. Yes or no?
Yes, sir.
For to be talking to you. Now comes the question of tuberculosis being a factor where the patient could have some effects of certain drugs. What are the drugs that have an effect on neurological system? ATT, the drugs on, please sit down. The blue shirt.
That's what means it.
No, blue, this is blue. What did I ask? Which drugs have effects on central nervous system? That's what I'm asking. Or nervous system or neurological system. Okay, let's make it simpler. Name the anti-tubercular drugs. Nobody prompts. Excellent. Which of them has a side effect? Optic neuritis has a side effect. Only. Okay. Which of them has the major effect as hepatotoxic drug? Okay. Which of them has a major effect on nervous system? So, when you're sitting here, pay attention. Getting my point? I am here, so I'll be attentive. If I'm not here, I won't know what is happening. Sit down. Now who's going to complete that?
So actually, as it has prominent CNS.
Good. How about the other questions that I asked, which he could not answer, which are basic?
Ethambutol causes optic neuritis.
Narrowing to scotoma, okay?
And rifampicin is primarily hepatotoxic.
Can precipitate hepatic coma in a patient who's hepatic.
Pyrazinamide is the most hepatotoxic drug.
Pyrazinamide is?
The most hepatotoxic drug. Most hepatotoxic drug.
And isoniazide. What does it do?
CNS side effects.
What side effect?
Peripheral neuritis. Peripheral neuritis.
3 P's. Pellagra, psychosis, peripheral neuritis. Rifampicin. All secretions red. Hepatotoxic. Ethambutol. Narrowing of the optic field. Scotoma. And perception of which color is gone?
Red and blue.
Green is also gone. Or everything looks green or everything looks red?
Everything looks
I think it looks all green.
All green.
And third one?
Pyrazinamide.
What is hepatotoxic? Well, you should know that. That's very basic. Please sit down. Now here is covered it well. I am happy. Journal physical examination, performance status, nutritional status, and he mentioned BMI also. The patient is undernourished. And don't say hydration. Patient is hydrated. It will come in the next slide. It's here. Patient is hydrated. Patient is well hydrated. Or the hydration status is good.
Good.
Pallor is present.
Yes, sir.
Roid is absent. There is no pallor. What do you mean present? There is no yes. There is nothing like present, absent, Clear? So patient has no pallor. That means he is not anemic and he is well hydrated.
Patient was anemic.
Okay. Patient has pallor. Pallor is present, is no state.
The patient has one.
You're not understanding what I'm saying?
I get it, sir.
Usually what happens is pallor present, equal is absent, so and so present, so and so absent, and you're so used to it. That's the wrong way to describe it.
Patient has
Not the correct way. He's febrile, pulse rate is 82 beats per minute, now bulimic, respiratory rate this much, palpable notes in the axilla. When you say both sides, it will become axilla and neck, which are bilaterally present. Again,
Yes,
present,
sir.
absent, doesn't work. There are palpable notes in the axilla and the neck.
Okay.
Now just look at this picture, that's why I had stopped you there. You should have described it better. Examination of the axilla, the right and the left. What do you do in the examination of the axilla? You have missed out many things, that's why I wanted to stop.
This picture.
There is no visible ulceration except in the axilla. The breast appears now. Axilla drains the breast.
Yes, sir.
So you need to, it is visible in your picture.
Breast is normal.
Thank you. There is no arm edema. I'm telling you what all is missing. Why is that important? I'll tell you. There is a visible swelling which is of the size 3 to 4 centimeters. Not, you said 2 centimeters in diameter. In diameter is known as spheroidal swelling. You don't see the other side. It is a flattened thing inside, so how would you have a diameter? So as it is appearing to you, it is maybe 4 into 3 centimeters. The visible erythematous changes, features of inflammation, there is redness. There are few discharging sinuses present along the posterior axillary fold. It has this place as boundary, which you should know.
Yes, sir.
This is posterior axillary fold, this is anterior axillary fold, this is the apex, and this is the base of axilla. But describe it from that point of view. Completely occupying the axilla except for a strip of skin which is normal here. It's all inflamed. And there are multiple sinuses in addition to a inflamed swelling or inflammatory swelling. Then on palpation, local temperature is raised. It is tender. Size is confirmed. On pressing, there is discharge. And there are multiple discharging sinuses and there is induration around them. Even if you don't palpate, I can see the induration, although induration is always felt. If you really look at it, this should be all fibrotic here.
Yes, sir.
It actually is. You can feel there is induration. And induration would signify fibrosis, which would signify, what would fibrosis signify over here?
Secondary.
What would that signify?
Granulomatous.
Immunocompromised patient will have healing. Well, that's okay. So what else?
Granulomatous
Chronic
infection.
inflammation. That's very well answered, and that's what I was looking for. So it is an acute and chronic inflammatory process. And that will justify your history and that will justify your diagnosis. Something that you missed out. This is all about this patient, this story. The features of acute inflammation here. These are features of
Chronic inflammation.
There is an acute or chronic inflammation. And the process is very obviously visible, especially on this side. You can then describe there is a small ulcer here. Here, as I'm showing with my cursor. Even here you find this complete axilla is involved. There are features of chronic inflammation and also of acute inflammation, which means acute and chronic inflammation, which means exacerbation of recurrent acute inflammation, which means something which is chronically present but keeps becoming acutely exacerbated each time. And therefore you need to look for a reason. You getting my point? In this patient, generalized lymphadenopathy is very important, which you described in only one statement. Palpable nodes in the axilla and neck. If you do not describe neck nodes properly in this case, your examination is incomplete. Why? Why is it incomplete? No, you can sit down. He's answering, then you start.
Because the continuation of the infection is all the
You? Look, yes? No, you're getting into the unnecessary microbiology of it, which I'm not asking. Tuberculosis is a cause of generalized lymphadenopathy. And what is generalized lymphadenopathy, Rohit?
So it involves the cervical lymph nodes as well as.
Answer this properly. You're not answering it properly. I'm very, very disturbed. Generalized lymphadenopathy I must have covered million times in my class.
more than 1 year, not for more than 3 months.
My God.
More than 3 non-continuous.
Anybody here? Ayushi?
No, non-contiguous
Regions of lymph nodes.
regions.
Clear? Sit down. Now, please don't do that blunder. It's a very basic thing. Generalized lymphadenopathy is when two or more than two non-contiguous regions of lymph node are involved, not two lymph nodes.
Regional.
An inflammatory cause, most common inflammatory cause of generalized lymphadenopathy is tuberculosis. I am interested in knowing what happened to the cervical lymph nodes. You didn't describe it. You just mentioned palpable lymph nodes in the axilla and neck, which are bilaterally present. That makes no sense. So, what is glaringly missing is examination of cervical, inguinal, popliteal, and other lymph nodes.
Okay.
You thought it's over. It's not. I will discuss this as a case of generalized lymphadenopathy. You will discuss it as a case of tubercular lymphadenopathy of the axilla. Look at the difference. Difference is, I'm through with flying colors, you had it. Maybe a client examiner will give 50%. A good looking student presenting reasonably alright, 50%. That's not good for you. Generalized lymphadenopathy is when two or more than two non-contiguous lymph node regions are involved, and this is the case. Now what is missing there? Well, let's catch up. Everybody else would have also missed, so don't feel bad about it. It's good to miss here, but not to miss there. Two, cervical and axillary. Which all groups of cervical lymph nodes are enlarged?
So,
There you are.
Three,
You describe the
four.
levels now.
3, 4, and 5B.
So level 3, level 4, please come in.
Level 5B.
5B means
In the posterior triangle, the 5A and 5B, so the lower
they
part of
needed
the
to be
posterior triangle.
described. If you had done that, it would have become a classical case, and my diagnosis would be different. I'll tell you how I'll put it up. The whole story changes. So the lesson to be learned is, don't get stuck with one finding which you are looking glaringly visible, or you think that examiner is also going to discuss just the axilla, why should he discuss anything else? And he'll just be looking for one such student who describes both cervical and axillary lymph nodes, so that he can give good marks. Clear? So here, this would have been a different story if you had described this. Movements at the shoulder, and when you're examining for breast, today they were presenting a breast case, you examine the axillary nodes. What did I say? What is missing?
Supraclavicular.
Even here it will be missing. What is stopping this causing inflammatory involvement of the lymph nodes in the supraclavicular nodes? In this case, patient has bilateral axillary nodes. Cervical lymph nodes. It's a case of generalized lymphadenopathy.
Yes, sir.
Palpation, we already covered this. Thank you. Now, foul smelling, copious discharge, palpable lumps in the vicinity. What is that lump?
So there were anterior and apical group of lymph nodes which are
So they are not lumps anymore. What are they called here?
Undulations,
nodes.
lymph nodes.
Describe axilla. Don't describe swelling. If you describe the axilla, the swelling gets covered automatically. And what do you describe in an axilla? Appearance,
Margins.
skin,
Yes, sir.
and the lymph nodes.
Yes, sir.
What are the groups, anatomical groups? Anterior, posterior, central, lateral, apical.
Apical. Yes, sir.
Clear?
Yes, sir.
On surgery, level 1, level 2, level 3. You can't do that in classification clinically. But here, I understand what has happened, and your presentation is not bad, but try to understand where it can go.
Yes, sir.
It can get better. So you say the other palpable lymph nodes in the axilla are how many?
Anterior and posterior.
How many?
So 3 in the anterior.
So maybe 3 in the anterior group,
And
4 in the posterior
posterior.
group. Describe both sides.
Firm. Non-matted.
Firm, tender.
Not
Are they
tender.
matted?
Not matted.
Everything is important from it.
Yes, sir.
That's not described here. Why is matting important?
So
Everybody
tuberculosis.
loudly. Speak your gibberish, I'll follow. Everybody, we're all props, everybody started, so speak now. Why match it? Yeah. You answer that now. Yes, you, sir. Taking very long to get up, I know.
Because of dissemination.
What would matting indicate?
That it has proliferated, the lymph node has.
What does it indicate in terms of a disease?
It has spread.
Granulomatous and caseous necrosis.
Which disease will have periodontitis? But this is the way you
Tuberculosis.
differentiate tubercular lymph node from lymphoma, where the nodes are not matted. In tuberculosis, the nodes are matted. I'm asking you a simple question. Sit down. Now, when you're examining the axilla, you will describe the nodes involved, palpable nodes, whether they're matted or not, whether they're hard or firm, whether they're soft, rubbery, everything. Rarely in lymphoma the nodes can get matted. Commonly they don't. And when it happens, that is due to periodontitis, not due to lymph node getting inflamed. Here the whole damn lymph node is inflamed. There is nothing remaining. Tuberculosis is known to produce matting. We know that, I think.
Yes.
No confusion. You got confused there. It is matted group of matted axillary lymph nodes bilaterally. Now I'll be interested in knowing about the cervical lymph nodes now.
So in cervical lymph nodes, they were 1 to 2 centimeter enlarged.
They are matted, I've seen this patient.
Matted.
Patient was written in the OPD, no?
Yes, I know OPD.
I don't know when, but I can make out. Cervical lymph. So you need to describe which levels, which groups,
Size,
consistency,
number.
numbers, matting,
Matting.
no non-matting, tenderness, everything. You'll have to tell me at the end of the day, it is an inflammatory involvement of the lymph nodes.
Yes, sir.
And how do you tell me that? Unless you find out whether it's tender or not, matted or not, firm or not. It's not hard, which is ruling out a malignancy. And why did I want you to examine the breast? Because that's the area that drains. That is drained by
Axilla.
So give me every reason which excludes everything else except malignancy. Then I'll come to your diagnosis. That all is missing there. Examination of cervical lymph nodes is missing. So we have a case. And what would be your diagnosis now? Can you make it? Diagnosis. Give me a good diagnosis. Didn't give me any diagnosis.
The
Now
diagnosis.
what is this swelling currently present on his right underarm? What is that?
So right axilla.
Is single. There is axillary lymphadenopathy. There are 4, 5, 6, whatever numbers you said. Firm in consistency, matted,
Matted appearance.
non-tender or tender, discharging, and they are communicating with this swelling, which is tender, firm. There is fluctuation present
Fluctuation
in
is
this
present.
because it's just about to open up.
Yes.
So diagnosis.
My 28-year-old gentleman, my patient 28-year-old gentleman who has presented to the OPD with a bilateral.
Presenting to the OPD is not a part of diagnosis. Now you're already done with all that stuff. Patient is for a diagnosis. You've done your history, you've done your examination.
With a chief complaint of
No, diagnosis. Who's going to give it?
Patient will be old with discharging sinus in his both the axilla and the lymph nodes palpable.
How do you give a diagnosis? We've done many cases by now.
So, patient 28-year-old gentleman with multiple discharging sinus in the axillary, who's a known defaulter of tuberculosis treatment.
diagnosed as.
It is, other things also there.
28-year-old gentleman with multiple discharging sinuses in both the axilla, and who's a TB treatment defaulter, and so he's most likely.
Okay? Would you like to make it better? Yes.
So, the patient, 28-year-old gentleman presented with multiple discharging sinuses.
Now see, I think you're repeating it. So, 28-year-old gentleman with, don't have to say my patient now. He's your patient. And he came to the OPD. And he came by bus or train. That also doesn't need to be mentioned. Now it's a diagnosis. 28-year-old gentleman with generalized lymphadenopathy.
Okay.
Clear? Probably due to an inflammatory etiology. Presenting with discharging sinuses in both the axillae, likely to be tuberculosis. That's it. Clear?
Yes, sir.
Repeat that, please.
28-year-old patient.
Sit down. You will come here.
Gentleman.
I'm very fussy on these things. Yes.
Gentleman. So,
28-year-old gentleman with generalized lymphadenopathy with bilateral, probably due to inflammatory cause with bilateral discharging sinus, this may be due to tuberculosis.
Give him a big round of applause for repeating what he just heard. It's a big deal now. Now, we have a case of generalized lymphadenopathy. Why did I make it broader? Why? So that you can discuss the case well and you can score your good marks. If you just call it axillary sinus, probably tuberculosis, and then explain in the reasons as generalized lymphadenopathy being a background, you lost it already. So what would I do? I'll make it into a generalized lymphadenopathy in any case. Generalized lymphadenopathy, 28-year-old gentleman with bilateral axillary lymphadenopathy and sinuses, probably due to tuberculosis, probably due to an inflammatory cause due to tuberculosis. What have I done? I have thrown 4 punches at the examiner. One, generalized lymphadenopathy. He's going to ask you what is generalized lymphadenopathy, and hopefully you'll answer now. Then you also thrown due to an inflammatory etiology. He's going to ask you why inflammatory, and that you will answer. Why inflammatory? Who's going to answer that?
So,
Okay.
because the lymph nodes are batted, firm, and top.
there is swelling, there
And
is
with the
tenderness.
discharging sinus with evidences of chronic inflammation with fibrosis present in the axilla.
Please sit down.
Signs of both acute and chronic inflammation is present. In acute inflammation, the skin over there is firm, tender, raised temperature, red, and in for chronic inflammation, fibrosis is present and discharge.
How would we give it? I've taught you how to.
History.
And
On examination.
Now give him a round of applause. There is only one alive person. Okay, what on history?
History.
You took the history, so.
It's a chronic history with there is bilateral.
There is a history of default.
Hmm.
So somebody diagnosed him as tuberculosis sometimes.
Yes,
There is an important history.
Yes.
There is history of constitutional symptoms. So basically, when you are asked this question, why don't you remember this? So many times I have discussed it. Answer it in this manner only so that you are able to reproduce your answer. Points in history and points on examination. You just can't start off wherever you like. The points in history would be history of constitutional symptoms. History of having taken anti-tubercular treatment and defaulted. There is history of evening rise of temperature, and tuberculosis is the most common cause of lymphadenopathy in this part of the world. On examination, they have all spoken on examination. There is generalized lymphadenopathy, lymph nodes are firm to rubbery, firm in consistency, tender, and then discharging, and they have matted.
Right.
If you had not described this, then you won't be reaching the diagnosis. Is that clear now?
Yes, sir.
Please sit down. So that's your case. You have a patient who's got generalized lymphadenopathy, and this is due to tuberculosis. Can this go on?
Yes, sir.